Talk a little bit about criteria for analysis of pleural fluid, IPC, talk about the Talc Pleurodesis and the indwelling pleural catheter. And we're going to talk about head-to-head comparison between both of them for recurrent malignant pleural effusion. Here's the structure of the pleura. This is the pleural space, a potential space. We make about 0.25 milliliters per kilogram. Low protein fluid. Rate of secretion is about 0.6 milliliters per hour, and that's essentially about the same rate of absorption. If the secretion is a little more, the parietal pleura, which does the secretion and the absorption mainly, can increase the capacity up to 40 times. But if the rate of production due to a disease or underlying pathology increases, then the visceral pleura can jump in for help. Structure of the pleura, we have the parietal pleura and the visceral pleura. For the arterial supply, the parietal pleura, close proximity to the intercostal artery, gets blood supply from there. Visceral pleura gets it from the pulmonary artery. For the nerve supply, parietal pleura is sensitive to pain, pressure, temperature, touch, while the visceral pleura is only sensitive to stretch. Parietal pleura, same, gets nerve supply from the intercostal nerves and phrenic nerve, anatomical proximity, while the visceral pleura gets it from the autonomic nervous system. We're going to talk about the exudative versus.
I think the point that you highlighted, so usually like when the pleural effusion develops, the problem is in the reabsorption, because if it's all production, so the pleura can ramp up the absorption, so it can absorb as 30 to 40 times what it makes. So usually like there's a problem absorbing, not making the fluid.
Like I said, and objective number 2, we're gonna talk a little bit about the exudative versus the transudative effusion. Just we're gonna view Light's criteria. You all know it. This is just a review. Pleural fluid protein to serum protein 0.5, or LDH ratio 0.6, or the pleural fluid LDH greater than 2/3 upper limit of normal. This is Dr. Light's criteria, and they have 97% sensitivity, but this on the affects the specificity. It's 80% specificity. They even did modified Light's criteria, trying to make it even more sensitive. So it's a 3-test rule. You need one to be positive. You either have the pleural fluid protein more than 3, or pleural fluid cholesterol more than 55, or the pleural fluid LDH more than 0.45, the upper limit of normal, which is cutting it too low, and like I said, increase the sensitivity vastly, but this is on affecting the specificity. There is just review some additional testing that can be done to the pleura, as we all know.
And you know why they went to make it more sensitive, right?
Yeah, because you don't want to miss an exudative effusion because of the underlying pathology that causes it.
But with the way that we use all the time, not the modified, around 20 to 25%, the pleural effusion will be misclassified as exudative. But we still can use the clinical judgment, how we think this is pleural, CHF or cirrhosis, good diuresis, you get your albumin ratio, gradient, and the routine gradient. So about 20% of the time it misclassifies, but this is the best.
This is the best we have, but this the sensitivity is key here. We're going to talk about malignant pleural effusion. It's like all we know, it's a manifestation of advanced intrathoracic malignancy. The survival after diagnosis is up to a year, more than 125,000 hospital admissions a year. And look at the cost. It's immense cost. Inpatient costs about 5 billion a year. The main tumors that causes that are the lung and the breast. They have the big share of up to 65%, followed by lymphoma, genitourinary, and GI tract for the rest. Malignant pleural effusion is the second leading etiology of exudative effusion. Now, the main question that we have today is that in patients with symptomatic malignant pleural effusion, with known or suspected expandable lung, no prior definitive therapy, should IPC or chemical pleurodesis be used as the first-line definitive pleural intervention? In other words, if we have a patient with malignant pleural effusion that's gut drained and the patient experienced symptomatic improvement, same patient comes again with recurrence of the effusion, should we do IPC or chemical pleurodesis for definitive therapy? Before they created the Pleurex catheter or Aspira catheter, Talc Pleurodesis was number one, was the first agent of choice, the first procedure that gets done. Talc, the only downside to it, or one of the downsides to it, is that you have to have a very close approximation between the two layers for you to be able to achieve pleurodesis. That's not the case in intrapleural catheters. You don't really have to have that. At least 30% of the patients have non-expandable lungs, so they're not candidates for talc pleurodesis because there's no approximation. Here comes the rule of IPC, is that it was originally made for those people, unexpandable lung, recurrent effusion, no approximation, nothing else to treat it with. So IPC was actually a very convenient way of taking care of that. Now, later on, they expanded on the use of IPC. Should we use it for even patients who we could achieve more than 90% expansion instead of just talc pleurodesis? And this is the subject of our discussion today, is to compare. Let's talk a little bit about pleurodesis.
Compare the
IPC to talc pleurodesis. For pleurodesis, as we all know it, it's a procedure performed to obliterate the space, the pleural space, for recurrent effusion or pneumothorax. A lot of ways to do it. Can be done mechanically, either by abrasion or parietal pleurectomy. This is for our colleagues in surgery, not for us. Chemical, that's where we come, either talc with doxycycline, or spontaneous, where the intrapleural catheter comes in. So the intrapleural catheter by itself, its presence there can actually cause pleurodesis. It's spontaneous pleurodesis. It takes time, and we're going to talk about that in the next few slides. For talc pleurodesis, I know we don't do much of it here. We mainly focus on Pleurex and Aspira placement. I was fortunate enough to do a few of them. We're going to talk about it in just a little bit. It's talc is hydrated magnesium silicate. I'm not a chemist, so I don't know what that is, but I included it for whoever is interested. It was first introduced in 1935. The sterile talc powder, it's you order it from the pharmacy. Most of the time, they pre-mix it for you, which I don't like. I like when they send me the bottle. It's 4 grams, made by a company called Novotech, or the spray. That's not for us. That's for the surgery, made by a company, Bryan Company. Those are the ones that have been approved by the US for the use. So there is a big problem about the Novotech, that we use. The bigger the talc powders are in molecular size, the bigger they are, the less likely they can cross the barrier between or in that case, in that instance, the visceral pleura, the less likely they can cross and cause inflammation of the lung. In Europe, the manufacturers are required to provide the percentage and the molecular size of their preparation, meaning, for example, they would say this talc powder, the particle size, it's less than 10 microns or more than 10 microns. The percentage of the small particles are about 10% or 15%. The higher the percentage of the small molecular or of the small size talc powder, the more complication you will get. In Novotec and the formula approved by the US, they don't provide that, and they are not disclosing it. And in one of the studies, when I was preparing the article, in one of the studies, it was up to 25% small particles, which can be problematic. But this is not the case in Europe. The particle size, it's.
What are they using Europe?
I don't have the brand names, but less than 10% small particles, less than 10 to 15% small particles.
But here
That's
we don't know.
here we don't know. It's not disclosed, but one of the studies did analysis of the component, and they could identify up to 25% are small particles actually. So, like we said, the higher proportion of particle size that are small associated with local and systemic inflammatory responses. So, for talc pleurodesis, we have two kinds of talc pleurodesis. I'm not going to discuss doxycycline pleurodesis. There is studies comparing talc to doxycycline. Some people say doxycycline is superior. Some studies say doxycycline is not inferior, but that's not the subject of this talk. We're going to talk about talc pleurodesis and how it is used. So two ways: either patient chest is open and you do insufflation, the surgeon kind of sprays it. I don't know how they do it. I'm not a surgeon. Or the one we use is we just, it's called talc slurry. We inject, mix it, and just inject it, forceful injection through the chest tube. This is pictures. Yeah, the aerosol or the Brian brand here. That's the approved one. Okay. So which one is better, the surgical one or the one that we do in 2005?
I don't want to jump ahead if you, in your slides, will you be talking about, tetracycline and, talc or not?
No.
So the only difference, I think, if you have someone, I don't know what is the basis of this, but I had to, contact one of the transplant, pulmonologists about a patient who might undergo lung transplant. I don't know, but he had recurrent pleural effusion. So they said, usually we don't like to do any kind of pleurodesis. They're going to undergo transplant. But if you have to, don't do talc. Do the other one, the, tetracycline. Maybe it will. I'm not sure about on what kind of scientific basis. But if you are doing, talc, I think this is the most commonly used. Okay, and you will talk about,
I'm going to talk about how it affects surgery.
Correct. And this is the only thing that I have in mind as, tetracycline as opposed to
talc. So in 2005, there was a randomized trial powered enough to get a result. It has 482 patients, greater than 90% expansion on the chest radiograph. So those patients are all candidate for talc. There was no difference between either pleurodesis done by talc slurry or talc insufflation, as you can see in the curves there. So the rate of success was 78% for the podrage or the surgical one and 72% for the slurry. But the difference was not statistically significant. Quick talk about the procedure. So you get a 4-gram bottle of talc. You mix it with 50. You get. Usually how I did it is I got two big syringes, 50 ml each, and I injected the 40 milliliter of saline into the 4-gram bottle of talc. So now I have 50 grams or 50 milliliters. Then I I suction all of it and connect a 3-way to the chest tube, close it to the patient, agitate it with the 2 syringes. So that's about total of 100 milliliter, 50 on each side. You keep agitating, and then you inject it into the chest tube. Some providers give 25 milliliters of 1% lidocaine intrapleurally few minutes before. Some providers also use bupivacaine instead. Some use both, though I know Dr. Lastal uses both. So like I said, try to keep it agitated as much as you can before injection. After you inject it, let it dwell for an hour, then open the chest tube to drain it to suction. You keep the chest tube for 1 day, next day you remove the chest tube.
You have the chest tube to suction?
Gonna talk about talc pleurodesis safety.
What change in position?
I read, and I didn't get into details, but theoretically, what I thought is if you change position, you try to tell the patient to switch from side to side. I didn't find anywhere that says you need to do that. I think it's theoretically.
Yeah, I mean, this is what I'm saying.
Yeah.
It makes sense, but is there any data to support this?
I didn't find any data. Maybe I didn't look deep enough, but from what I looked, I didn't find any data. But theoretically, this is not like insufflation. This is not like the podrage, so you don't spray the whole surface. So mechanical movement may help spread it. The most common adverse effects are fever and pain, and I usually tell the patient you're going to have a pretty bad pain the next day. Some studies actually said they don't, if your patient is on steroids or NSAIDs the few days before, this may impair the efficacy of pleurodesis because it works by creating an inflammatory response. So if your patient is on steroids or NSAIDs, you probably may want to delay the procedure. Less common side effects, and actually very less common: arrhythmia, dyspnea, respiratory failure, systemic inflammatory response, and empyema and talc dissemination. So like we discussed before, the systemic inflammation or even the respiratory inflammation, if you were to develop ARDS or systemic inflammatory response, this is directly proportional or inversely proportional to the particle size. The smaller the particles are, the more chance you may develop systemic inflammatory response or respiratory failure. Now, the long-term adverse effects, surprisingly, there is no significant impairment in lung function, no significant development of lung fibrosis, no increased likelihood of cancer, and talc pleurodesis does not preclude subsequent ipsilateral lung surgery. So it's not a contraindication to lung surgery, but does it affect the lung surgery? I don't know. And Dr. Al-Jarud mentioned that one of the surgeon prefers.
And the multiple, because he, at least that I know, he worked in 3 different transplant centers. He said it's not contraindicated, but avoid talc, as most surgeons, they don't like it. In what phases, I'm not sure, but if we have to, and you don't have any other options, you may need to avoid talc.
So now we'll get into the core of the comparison. In patients with symptomatic malignant pleural effusion, and I should say recurrent, with non-expandable lung or loculated effusion, should we use IPC or chemical pleurodesis? We have 3 trials and I think 2 or 3 meta-analyses. Let's start with the ample trial. The ample trial was trying to answer one question: is IPC better than talc pleurodesis in reducing total hospitalization days? They're not trying to assess which is superior, trying to assess reduction in total hospitalization days. And why is this important? Actually, the rest of the sentence tells you why this is important. They used those words in the study: in the remaining lifespan of patients with malignant pleural effusion, because their lifespan is short and the days are counted. So actually trying to reduce the total hospitalization days is not a bad idea. Regardless from the cost and all of that, but I like the wording of the study. Was in 2014, multinational, actually, not in one country, randomized trial. Of course, it's not blinded because of the intervention. 144 patients. Results were the IPC was associated with shorter hospital stay, as we can see on the diagram on the right side. Both methods provided significant improvement in dyspnea and the quality of life. However, there is no difference between the 2 groups in dyspnea or quality of life assessment, but there was a difference in hospital stay.
Favoring the IPC.
Favoring the IPC. A study was the Time 2 trial in 2012. The question was, is IPC better than TP in reducing dyspnea? Let's go back to the ample trial. Ample trial didn't find any difference in dyspnea. The only difference was in hospital days. So is there any difference in dyspnea? So it was a randomized trial, 106 patients. There was no difference in dyspnea reduction between IPC and TP. All right. But in this study, IPC was found to be associated with actually more side effects than talc pleurodesis. So on the right, talc pleurodesis, on the left, IPC. The pleural infection was higher. Cellulitis was also higher. Symptomatic fluid loculation requiring use of fibrinolytics was higher, maybe not serious, but higher. The catheter blockage, of course, you're not going to have that in the talc, but it was found to be quite a significant number. So the total events, the serious events, were 9 compared to 5 in the IPC group compared to the TP group, respectively, and the non-serious were 19 to 4.
I mean, so if you look back, I mean, some of these complications we would expect, right? Because, you know, with IPC, you have a catheter that remains in place, so you'd expect infections to be longer. Catheter blockage will be more likely because you have a catheter that's there for a long time compared to a talc where the catheter may be there for a very short time and you remove it. So these are complications you would, you know, expect to be.
Because the other one is really more of short-term kind of complication. If you have to develop pain and respiratory failure and stuff like that, will be very early. But just you have catheter and you will be prone anyway. But it hasn't been documented that there's like any serious. So this one, like maybe cellulitis or infection to the point of having, you know, shock, stuff like that. So they're there, but I don't think that they were like in the study, the conclusion that they were like really something that we should worry about, right?
Maybe not in the study, but from actual life, I had two patients. I drained both of them. They both had malignant pleural effusion. No, let me take that back. One had recurrent malignant pleural effusion. The second one was recurrent exudative pleural effusion of unknown etiology. Both came to the hospital and both had pus just coming out, pus, and they both were very sick. I didn't, due to the change of rotation, I don't remember the course or the mortality. I didn't follow them for mortality. That's should have done a better job in that. But anyway, they both were draining actual pus.
But there's no longitudinal studies that looked into these patients as far as these complications, whether or not it's something
serious or not. I don't know.
When you did the literature review, you didn't come across.
No.
But here it says, you know, infection was 5 of them were serious. I don't know what that or the definition of serious was, but
correct.
Third trial is the ASAP trial. Okay, what's the question? This study is not comparing IPC to TB. It's actually comparing IPC to IPC, but the rate of achieving pleurodesis or spontaneous, because like we said, we have mechanical pleurodesis, we have chemical pleurodesis, and we have spontaneous. So for the spontaneous pleurodesis to happen, we usually instruct the patients to drain it every other day. Now, we usually instruct the patients to drain it every other day. In this study, they compared draining every day compared to every other day, and the effect of that on the timing to achieving autopleurodesis. That's a mouthful. It was a randomized trial, 150 patients. Like I said, drainage every day was associated actually with faster rate of autopleurodesis. The median range was 54 days, ranged from 31 days to 83 days, compared to classic every other day. That's our approach, which was 70 days to even longer, with the mean of 90 days. So mean of roughly 2 months compared to mean of 3 months. That's the study abstract, because I didn't get much time to get the actual article. All right.
So it's favoring the everyday kind of.
For achieving quicker autopleurodesis.
And the average is the other
how
one.
many days difference only?
About 34 days, 36 days if I did the math right. Here is, and if you drain it every day, it's gonna autopleurodesis roughly at 54 days, or that's the median, while on the other, if you drain it every other day, it's gonna be at 90 days. So now let's talk about the meta-analyses. This one was
report the cost of how that was costed, and how much that costed, right? Did they look into like it came with increased, you know?
It comes with increased cost, and as we're gonna discuss at the very end, it not just cost, but you also you need to have someone who knows how to do it, But sometimes this is your only escape if you can't achieve approximation. This is your only way. We have, now we talk about the meta-analysis. I think three or two I included in the slide. In 2019, was by the Narayan, if I'm saying the name right, I apologize if I'm not.
He's not here to hear his name.
Maybe recorded, maybe make it to YouTube one day. 545 patients, 5 big randomized trials. On the right, this is how much patients they looked into it and whatever they excluded until they reached 554. IPC was associated with shorter length of stay, fewer repeated pleural procedures, because talc pleurodesis may fail. Not because you injected it might not work. So from this meta-analysis, IPC was actually the one that was associated with shorter or fewer repeat pleural procedures. IPC was also associated with higher risk of cellulitis, as we may expect. Second meta-analysis, 2020, 500 patients, 4 randomized trials. They found that both TP and IPC improve malignant pleural effusion symptoms, which kind of intuitive. No differences in adverse events, okay? And the IPC was associated with shorter hospital stay. And this is the final meta-analysis. Talc pleurodesis had better pleurodesis rates, less total drainage, fewer all-grade complications. However, talc pleurodesis had more pleural procedures because of its failure, and as we know, is not feasible for patients with trapped lungs, since there is no expansion, no approximation, and IPC had fewer further pleural interventions, as was found in meta-analysis before, and shorter hospital stay. However, IPC has the nuance of long-term in situ drainage. This was a nice algorithm provided by Dr. Megri. So if you have a known or suspected malignant pleural effusion, asymptomatic, don't do anything. I said you can let it be. If it's symptomatic, you did the drainage, you got improvement on dyspnea. If you didn't, then you stop there, look for another reason for the dyspnea. I don't know if you can see, yeah, you can see it. If it improves, then you ask yourself, look at the X-ray, did you achieve lung expansion? Let's say, no, you didn't. Then overall survival, is it very short? Then just palliative. You don't want to subject them to intervention. If it's not very short, then you probably would consider, since there's no approximation, your hands are tied, you're gonna go for the IPC. If the IPC with time caused lung re-expansion, you may consider either daily drainage, or you may even do another intervention and just get it over with and do talc pleurodesis. Because remember that those patients will have to drain every other day, and some of them might not have the capability to do that. Some of them may actually get sick of doing that, and they want a more hopefully permanent solution. Now, if you achieved lung expansion, well, it then comes to you and the patient. You both discuss. You decide either for the pleurodesis with talc pleurodesis or the IPC. And that's all I had. Thank you for listening. Any questions? Thank you.
Thanks.
Time management.
So we know what would you do for your patients? To do Talc or Pleurodesis or IPC?
Depends.
If what I did, mostly it's driven by tendons, but if it's
21 days.
if the life expectancy is less than 6 months or less than a year, I would do the IPC because it's shorter hospital stays,
You said life expectancy less than a year?
less than a year.
You do what?
The intrapleural catheter, less than a year. That's assuming we have lung expansion in both cases. Life expectancy less than a year, they shouldn't stay in the hospital for long. They can put the Talc Pleurodesis if they have good social support to help, or if they're able to drainage, then the intrapleural catheter can stay in for this time. If its life expectancy is expected to be longer than this, and I have good approximation, I would personally try the Talc. So.
I mean, most of the patients you'll see will probably have a very low life. I mean, most of them are, this is stage 4 cancer, a lot of expected mostly months. So, yeah, I think if most people go with IPC, I think now just because of a lot of the benefits and the complications that you talked about is usually for prolonged cases, but most of the mortality is, or the mortality is so high that usually they don't survive long enough to develop these complications, which just gives you, which I think helps you with deciding that you should not, technically you should not be putting pleural catheter for non-malignant effusions if they have a long, because these people may, don't have a mortality of a month. They may have, so they'll have complications from sterilitis, infections, and pus, and all that stuff like that. Those patients, they may have it. So
I don't know if there is a data about using it for